May 29. We are now at 735 cases, still 25 reported deaths, currently 3 hospitalizations, 307 home, and 400 recovered. A case fatality rate based on confirmed positives of 3.4%, and monitoring of exposed or travel-related folks has now gone into the nearly 1,000 range, with 76 of them currently being actively monitored. That still has us at less than 1% hospitalized. And then this is our hospitalization trend over the last, going on 2 months now, where you can see really for the month of May, we've been down here in the less than 5 Ingham County residents hospitalized on a daily basis. We got down to 1 at one point and hovered at 2 for a while, back up to 3 now. So that has us with 54.8% recovered, 41.4% at home in basically mild illness recovering, 3.4% deceased, and less than 3% hospitalized, less than 1% ICU. So this is our cumulative curve of cases by date of onset, starting in February. This chart starts, I think it looks like we had our first onset case somewhere around early March. So here's our incidence curve. Actually, we have our first cases here in the 20th of February. So that backed us up to, date of symptom onset with cases. And this is what our curve or incidence curve looks like overall. You can see that we had a spike in cases this last week on that day, but overall, what we're also seeing is this nice level trend of percent positives per day, down from where it was. So really trending here fairly flat in the number of positives per day of the total tested. If you take that and create a rolling average, our rolling average of incidence looks like this, the gray bars, and our rolling average of percent positives per day is the blue line. And you can see we had that slight uptick that we talked about, and now we're going back down in terms of the percent of those that are positive on a daily basis. We're less than 2% at this point. Looking at cases by zip code, we still have 48911, now in the 221 to 230 range, followed by 48910, 48823, then jumping down a case range for 48854, 48906, and 48864. And then you can see the rest of those numbers there as well. When we map those cases just by strict numbers of cases in these zip codes, we have, obviously the 48911 zip code with the darkest shading, and then 48910, 48823, and then this is the 48906 and the Mason zip code as well. When we look by rate, which is a calculation per 100,000 population, since the zip codes have different populations in them, I just happen to know 48911 is about 40,000. So we look at those cases per 100,000 population, and then we see still 48911 in that highest range, with the Mason and the 48910 following in that next lighter blue shading, and then we go to these kind of blue greens here. Our heat map still looks fairly similar. This is a zoomed out version. You can see the entire county. And if we zoom in a little bit, you can see still, a lot of hot spots here in 48910, and then picking up 48910 as well. And then this is 489, either 12 or 15. This is 48906 over here. So our percent cases by sex breaks down to 49% male and 51% female. Our age group, this graph has been looking pretty much the same for a long time now. So, you know, we are getting relatively few cases added per day. So a lot of these demographic numbers are not going to change wildly on a day-to-day basis. So when we look at the percent cases confirmed by race, we see that it's 48% Caucasian, 28% Black or African American, and 16% Asian. So that shows us that most of our cases are in Caucasians, but again, most of our population is disproportionately also Caucasian. So when you calculate by rate, in other words, adjust all populations to 100,000 and then say how many cases are there if there were 100,000 of any of that demographic, we get these numbers where we see other at 669, Asians, African American at 618, and Caucasians at 163. So we're looking at 3.25 to 4 times the prevalence rate in our African American, Asian, and other populations compared to our Caucasian populations. When we look by ethnicity, we have 84.9% of our cases that are not Hispanic or Latino, 11% are Hispanic or Latino, and we're down to only 4.1% now unknown. And so that rate looks like this: 231.4 not Hispanic or Latino, 351.2 Hispanic or Latino. This time, instead of going through a bunch of 48911 demographics for you, which I know you'll all miss greatly, again, because numbers don't change a whole lot on a day-to-day basis, most of the graphs that I showed you before are still pretty much the same demographic breakdowns in 48911. And we know that we're in the 3,800 or so in terms of our rate for Asians there compared to our other populations. So we know that we have that extreme rate difference in that particular zip code. We do have a number of outbreaks that we are tracking in Ingham County. So we have a few long-term care facility outbreaks that people are talking a lot about long-term care facilities, as well as we've talked about the Meyer Warehouse outbreak, the Herbrooks outbreak, some cases at Peckham, cases at KTM. I've got an other in here because there were a few other small ones. But the ICMCF is Ingham County Medical Care Facility, excuse me. And then Bircham Hills, you can see Metalodge, East Lansing, Metalodge, Okemos, and then a few cases at Vista Springs. The outbreaks out of our total cases are this represents 220 of our cases associated with these various outbreaks compared, relative to our total number of cases, which was, I can't even remember now, 730 something. So if we look now at deaths by age, we have 12% at 50 to 59. We have 20% 60 to 69, 28% 70 to 79, and 40% over 80 years old. If we look at that breakdown by sex, they are 52% male, 48% female. If we look at that breakdown by race, they are 64% Caucasian, 4% other, and 32% African American. If we look by ethnicity, we see 84% that are not Hispanic or Latino, 8% Hispanic or Latino, and 8% unknown. And that is your data update for today. So now I'm here to answer questions.
If anyone has a question, feel free to go ahead. Dave Ackerley.
Linda, when you were showing the graph on prevalence, the highest prevalence, there was Black, Asian, Caucasian. The highest said other. What is other, and what is that? What does that entail?
That's going to be like Native American, American Eskimo, some populations like that. That just really, the numbers are so small. As soon as you have a case or two, then that rate gets really, really big. And keep in mind, just like calculating prevalence rates for zip codes. Remember, we dropped off calculating that rate because we had less than 20 cases. When you get into those small numbers of cases and you calculate that rate, you know, you're going to see things like that, and it's difficult to really tease out sometimes exactly what's going on, but it's those populations in other.
All right, thank you.
Mm-hmm.
Linda, it's Jam from 6 News.
Hi, Jim.
The governor was just asked when the next regions might open, and someone specifically said, you know, maybe regions 5 and 7. The governor says, as a matter of fact, I'm having a call tomorrow about this. I know you've spoken about this before, but it seems that we're getting closer to perhaps a reopening of Region 5. What is your, or have you been part of those discussions? What's your take on how soon we might see Region 5 start to see some relaxed restrictions?
I have not been part of those specific discussions other than watching the data myself and watching data across the state. And, you know, you all heard me last week saying that I believe that our region was poised, you know, to be, you know, amongst the next regions to open up. So it doesn't surprise me. That seems to be where we've been trending. We have, you know, what's referred to as the gating criteria, you know, that people are looking for in order to open up, you know, daily incidence of cases trending downwards for 2 to 3 weeks at a time, percent positives trending downwards for 2-3 weeks at a time, as well as that hospital capacity, which I've been able to show you. They are working on a new dashboard, which I hope to show you next week. There was some kind of data missing in it, but the state did create a dashboard that's a little bit more informative. And there's a public side to that, and there's also a public health side to that. So depending on what I see in there, I might be able to share with you all some of what we actually see on our side of that, as well as what you see on yours. But they're just getting that up and rolling. Anyway, so the bottom line is, you know, tracing the data, watching the data, I'm not surprised. And I do believe that this region has done a great job. We've done a lot of testing. I think probably the testing capacity and the incredible amount of testing we've been able to do has probably been a large part of getting us to the position we're in right now, which is really poised to be ready to start, you know, opening some additional things. So I was not invited to a conversation with the governor.
Thank you. Does anyone else have a question for Linda? Go ahead, Dave.
Linda, at the governor's press event yesterday, she actually, it was Dr. Caldoun who said contact tracing, there were 500 people trained. There was some discrepancy with the number that had been given out earlier by the state, which was 3,500. They told me that was a first training. These are people who've reached secondary training level and been background checked. I want to ask you, because they also told me these are people to kind of be there if public health people like yourself request them, but she said a lot of that's being done already by the public health departments. And being one of the bigger ones, is Ingham doing this right now? Do you have your own contact tracers? And do you anticipate you'll need any help from the state of Michigan in that regard?
Yeah, we do have our own contact tracers, and you're correct. I mean, health departments in this state are quite variable in terms of their resources and their abilities. And I will tell you, even the size of the county, you know, you can compare us to other counties of the same size, and we might be even resourced, you know, a little bit differently. And certainly one of the things that I do know in this area is that partnerships are incredibly strong. So we have, you know, had offers from the city, offers from county, you know, the county where they know that there are going to be some employees that for health reasons or age reasons that put them into vulnerable groups might be able to be diverted into contact tracing. We have done work with our university, the med schools, the nursing schools, and all kinds of places to bring on volunteers to basically do contact tracing, as well as redirecting some of our own staff. And we did actually tell the state, you know, this group of volunteers that you're training and getting ready to help local health departments, we'll take some of those too. Now, I don't think we had to take up the state's offer on a lot of those, but we did also put ourselves into that group. I can't remember the exact number they asked for. Might have been 10.
Do you have any idea how many you have of your own volunteers right now doing it?
No, I don't. I'd have to go back and count because it changes so frequently. I think the last time we asked and went back to count, it was close to 30. Amanda, do you recall? Because I think you had to double check that number for me.
I had a total number of contact tracers. I don't think that was necessarily volunteers. I don't think there were any volunteers when I got that number from.
Right, and that was about 30 then.
Yeah.
So we'll get to our, Amanda will help me follow up on that, and we'll get you an idea of how many people we have contact tracing already, as well as how many we're expecting from the state as a result of our request to the state to get some assistance there.
But based on the caseload right now, you feel like you're in a good position with that?
Yeah, I mean, you got to keep in mind that contact tracing also occurs to some extent with those folks that we've been doing active monitoring with. So as you can see, we're down to, like 97 or so, a fairly low number relative to the, 800 and something that we've completed. So that, that has been a contact tracing lift that has lightened quite a bit, and then just, daily incidence of cases. Now, as we reopen, we've got to be ready to do more of that. We don't, our hope is that we can, keep controls on things, keep case counts down, keep people remembering things like masks and social distancing and hand washing and all of that, so that we don't have an uptick in cases. But if we start to see upticks in cases, the importance of being able to test, contact trace, quarantine, and isolate very quickly is what will keep our numbers down. So we're going to keep ourselves at a good level of contact tracers on hand, even though numbers are going down right now, because we don't know where we're headed.
Thank you, Linda.
I don't have any questions in the queue, so if you have a question, please go ahead.
This is Rachel from News 10. I've got a question from the newsroom. So someone said that there's over 4,000 cases that are linked in the state that are linked to nursing home and over 1,000 deaths. Do you think that COVID-19 patients and those who have recovered should be banned from these places to stop the spread? And if so, where should these people go?
So I guess I'm not quite understanding the question. Are you talking about basically the placement, like these nursing home hubs where we're placing people who are COVID positive that no longer need hospitalization into a long-term care facility? Are you talking about those?
Yes,
or,
I believe this is.
Are you talking about keeping visitors out?
No, we're talking about the patients who have recovered that were in the nursing home.
Yeah, patients who have recovered, we need to get them back into nursing homes, long-term care facilities, and getting them cleared and back into long-term care facilities has been a bit of a challenge, but is getting easier. The other one that really, I think, gets more people concerned is that we have some people hospitalized that may have come out of a long-term care facility and no longer meet the criteria to be hospitalized. Because as you know, insurance companies require certain criteria to authorize payments for continued hospitalization. So they need to get released to a long-term care facility if they came out of a long-term care facility, but they need to be released to one that has the proper PPE, has the proper training, has the proper supplies, has the proper setup for keeping those cases while not impacting the rest of the population. And that's why this the long-term care facility nursing home hub situation was set up across the state. And those were identified because of their relative ability to meet all those standards, as well as have all of the things in place and have the PPE in place to be able to safely take those patients back. So I understand the concern. No, I don't think they should be kept out, because what are we going to do if we don't find a safe way to get them back into long-term care facilities that can safely take care of them and safely keep outbreaks from, running through the long-term care facility? And there are ways to do that. We've done that with norovirus outbreaks, influenza outbreaks. Long-term care facilities are always a source of, of outbreaks. And they're always, you know, things that we end up doing to get those manageable and back under control. And I will tell you that as I look at nursing home, long-term care facility outbreaks across the state and watch some of the ones that my colleagues have dealt with that have gotten really, really big, that we've done a really, really good job, once again, here in Ingham County of, you know, even though we've got some fairly significant numbers at Ingham Medical and also at Bircham Hills, of keeping those long-term care facility outbreaks to a really minimum number compared to a lot of the stuff that we've seen. So I'm comfortable with it. I understand, you know, the angst that goes along with knowing that that's part of the system that has to happen, but I don't know of a better way than finding appropriate long-term care facilities that we work with, that we know are appropriately trained, appropriately sourced, appropriately supplied, to make sure that we have a place that's safe to release people from hospitals back into long-term care facilities.